Endometriosis. Endometriosis involves the ectopic implantation of endometrial tissue in other parts of the pelvis. This condition occurs most commonly in the third or fourth decades of life and affects 10% of women of reproductive age. Endometriosis is the most common cause of secondary dysmenorrhea and is associated with pain beyond menstruation, dyspareunia, low back pain, and infertility. Treatment is directed toward removing the underlying pathology. Treatments vary from over-the-counter remedies to hormonal controls. However, for some women, satisfactory pain relief is difficult to achieve, and alternative options are increasingly being sought. Complementary therapies such as acupuncture are gaining popularity, and the evidence base for their use is growing. Therapeutic intervention is directed toward pain relief and building coping strategies that will promote a productive lifestyle. Treatment measures usually include treating infections if present, suppressing the endometrium if endometriosis is suspected by administering low-dose oral contraceptives, administering prostaglandin inhibitors to reduce pain, administering Depo-Provera to suppress ovulation, which thins the endometrial lining of the uterus with subsequent reduction of fluid contents of the uterus during menses, and initiating lifestyle changes. Endometriosis is one of the most common gynecological diseases, affecting more than 6 million women in the United States. This is equal to about 10% of the adult women population. In this condition, portions of functioning endometrial tissue become located outside of their normal sites, which is the uterine cavity. This endometrial tissue is commonly found attached to the ovaries, fallopian tubes, the outer surface of the uterus, the bowels, the area between the vagina and the rectum, called the rectovaginal septum, and the pelvic side wall. The places where the tissue attaches are called implants or lesions. Endometrial tissue found outside the uterus responds to hormones released during the menstrual cycle in the same way that the endometrial lining does within the uterus. At the beginning of the menstrual cycle, when the lining of the uterus is shed and menstrual bleeding occurs, these abnormally located implants also swell and also bleed. In short, the woman with endometriosis experiences several mini periods throughout her abdomen wherever this endometrial tissue exists. It is not currently known why endometrial tissue becomes transplanted and grows in other parts of the body. Several theories exist, but to date none have been scientifically proven. However, several factors are known to increase a woman's risk of developing endometriosis. This includes increasing age, a familial history of endometriosis in a first-degree relative, short menstrual cycles less than 28 days long, a long menstrual flow of more than 1 week, a high dietary fat consumption, a young age of menarche, younger than 12 years of age, and few, 1 or 2 or no pregnancies. Therapeutic management of the client with endometriosis needs to take into consideration the following factors: the severity of the symptoms, the desire for fertility, the degree of the disease, and the client's therapy goals. The aim of therapy is to suppress levels of estrogen and progesterone, which cause the endometrium to grow. Treatment can include surgery or medications such as oral contraceptives, Depo-Provera, synthetic testosterone, and GnRH agonists. The 2 most common symptoms for women with endometriosis is infertility and pelvic pain. Endometriosis occurs in about 38% of infertile women and 71 to 87% of women with chronic pelvic pain. About 30 to 40% of women with this condition are infertile, making it one of the top 3 causes of female infertility. The pelvic examination typically correlates with the extent of the endometriosis. The usual finding is nonspecific pelvic tenderness. The hallmark finding is the presence of tender nodular masses on the uterosacral ligaments, the posterior uterus, or the posterior cul-de-sac. The only definitive diagnosis is one that's made during surgery. After a thorough history and pelvic examination, the healthcare practitioner may suspect endometriosis, but the only certain method of diagnosis is by seeing it. Pelvic or transvaginal ultrasound is used to assess pelvic organ structures. However, a laparoscopy is needed to truly diagnose endometriosis. Laparoscopy is the direct visualization of the internal organs with a lighted instrument that is inserted through an abdominal incision. A tissue biopsy of the suspected implant is then taken at the same time and examined microscopically to confirm the diagnosis. Thank you for watching.